Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today we have the pleasure of inviting to the podcast Dr. Michelle Lightfoot. She's from NYU Langone in New York, New York. And of course, we're going to speak about this very important article titled Oral Mucositis Associated with Antibody Drug Conjugates in Gynecologic Oncology, Strategies for Prevention and Treatment. I certainly do encourage you, if you haven't done already, to read this article because obviously it provides a great wealth of information regarding the side effects of antibody drug conjugates. So with that, Michelle, thank you so much for accepting our invitation. Thank you for your time, and thank you and all the other co-authors for submitting the manuscript to our journal.
Great. Thank you so much for having me.
So we wanted to start by just if you could tell us what are antibody drug conjugates and how do they work for our audience?
Yeah, so in general, I describe these to my patients as basically a form of targeted chemotherapy. So generally, you have a very specific monoclonal antibody that you want to be targeted to something that we expect to be on the tumor cells more than normal tissues. And that is connected to what we call a cytotoxic payload or the chemotherapy agent to be delivered. And those are connected by a linker, which is meant to hold the two pieces together and until it reaches the cell to be targeted, and then needs to efficiently release it once it finds its target.
Excellent. So with that, then let's start with this paper. And of course, obviously, antibody drug conjugates continuing to being increasingly used in gynecologic oncology. I think in most disease sites now we're using antibody drug conjugates. Now, let's talk a little bit about oral mucositis. How is it defined? And I believe you provide an outline of 5 stages of this condition. Can you talk a little bit about that?
Yeah, so oral mucositis, which is also called stomatitis, is basically inflammation and ulceration of the oral mucosa. It can also present as oral erythema or oral pain. And this is one of the side effects that has been noticed to be a little more common in some of the TROP2 targeted antibody drug conjugates. There is a lot more data about stomatitis that comes from treatment of head and neck cancers or stem cell transplant therapies. Essentially, the 5 stages that have been described are the initial event, so initiation, so when the cell damage first occurs, and that generates some reactive oxygen species. Generally, there's no symptoms at that stage, but following that, then you get the initial damage response and amplification. And so that through that process is where the inflammatory cascade starts to build. Sometimes you can have symptoms during that stage, but it's usually you wouldn't still see visible lesions. The next stage, which is stage 4, is really ulceration. So that's where you can see the visible lesions and where patients are really at increased risk of infection. And then the 5th stage is healing.
So with that, then let's get into the details as to how does it present, and for the physician, what's the best way to assess the symptoms of these patients?
Yeah, so a lot of times patients will have pain or soreness or erythema in the mouth. They can get the mouth sores or the ulcerations, but in more severe cases, this can start to affect their ability to eat or stay hydrated. It can start to affect their ability to speak and can even lead to really severe infections like sepsis or require hospitalization. So there are several different ways that you can measure this. Many of the guidelines come from the what we call MASC, or the Multinational Association of supportive care in cancer, and the International Society of Oral Oncology. And so they actually recommend using the WHO scales, or the common terminology criteria for adverse events. And so we outline those in the paper so that you can see an easy guide. In general, I would recommend that if you are using an agent that has a high risk of stomatitis, so 20% or above, that this assessment be done at least weekly so that you can be proactive in managing the patient's symptoms and really limit the impact that this has on patients.
Right, and you did mention with regards to some of the graphics and the figures in the manuscript, definitely wonderful job, and encourage all to take a look at them, because of course obviously they make the understanding of these processes a lot simpler. So with that, Michelle, we often will go to questions from our fellows in the journal. So the first question comes from Frederica Stroisch in Heidelberg in Germany, Heidelberg University Hospital. And she's asking, this paper describes two mechanisms behind the adverse effects, on target and off target. Do we know which of these mechanisms occurs more frequently? And are there promising strategies to prevent them rather than manage symptoms?
Yes. So yes, thank you to all of the fellows for contributing these questions. The short answer is we don't know exactly. Initially, it was thought that perhaps because there is high expression of TROP2 also in the GI tract, that perhaps this was an on-target off-tumor toxicity. But we've also seen that there is variation in the presentation of mucositis. So some of the TROP2 targeted ADCs have higher rates of diarrhea, for example, or nausea, whereas others have higher rates of stomatitis. And so what I think that suggests is that there are other mechanisms at play. And so that could be related more to the payload itself, or the linker stability, or bystander effect or diffusion of the payload to other tissues.
Great.
Yeah, in regard to the prevention, the mechanisms, I think some of the other questions were targeted at other therapies that show promise, but the truth is, I think we have to look at the design and maybe look at some of these other therapies that are used in other tumor types. So I don't have a perfect answer for that one right now.
But it's great to hear the sort of the mechanisms and the why we're seeing some of these side effects. And to that, Helena Obermeyer in Sydney, Australia, she's asking, your review notes significant differences in presentation of mucositis, such as diarrhea versus stomatitis, as you were referring to before, among the antibody-drug conjugates targeting TROP2. What do you think are some reasons for the different mucositis presentations observed among different TROP2 targeting antibody-drug conjugates?
Yeah, so I'll say I am not aware of studies specifically looking at, which of the elements vary. All of the TROP2 ADCs that we highlight in the paper have a similar payload. They're all topoisomerase inhibitors, but they're distinct. And we know that the side effect profiles can vary across standard topoisomerase inhibitors. So perhaps that's part of what's contributing. But they also have different linkers. And so when and how those drugs are being released, even if they share a target, might also be playing a role.
Rim Abu Chakra from Lebanon is asking now about the strategies that we use to address this stomatitis, and she's specifically says steroid mouthwashes have the most supportive evidence. Do you think it matters which one is used? And should patients on chronic steroid mouthwashes always take antifungal medications, or only if they get thrush?
Yeah, so I think That's a great question. I will say from what I'm aware of, the strongest data seems to support dexamethasone, and that's been used in more of the trials. That said, I think we have to also be mindful of what's available and to our patients and any financial toxicity. And so I did not find any data directly comparing these. I think it's simply that dexamethasone was used in more of the trials and is available. So that's what we use at our institutional in our institutional protocols for these trials.
Okay.
In
Yeah.
regard to the topical antifungals, I do think that's important because that is something that is not specifically recommended by the MASC and ISO guidelines. There is the rationale behind it is sort of twofold. It's not just the steroid mouthwashes, but it's, for patients who do get the ulceration, the candida is one of the infections that we worry about as causing secondary infections and worsening the oral mucositis and delaying recovery. That is not something that has to be incorporated. And so in the paper, we do say that's something you could consider. Some institutional protocols automatically include that as part of the preventative care in terms of, oral washes or lozenges. But that doesn't have to be incorporated.
Let's see. Yeah. So it's based on the practice of that institution primarily. Now, Mariana Carvalho from Sao Paulo, Brazil, she's asking a few questions, several questions in one. And she says, it's stated that holding ice chips in the mouth for 30 minutes before and during the infusion may be considered. However, do you think there's a biologic rationale to extend this approach to antibody drug conjugates, considering their long systemic half-life and prolonged mucosal exposure? And could antibody drug conjugates related mucositis be driven by an early high peak exposure phase that might still be amenable to localized cooling?
Yeah, so I thought this is a very interesting question, and I will say that in most of the studies for cryotherapy, they are looking at agents that are given over short time frames and with short half-lives. And so, in the protocols I could find where they even use these for, or they compared shorter to longer use of the cryotherapy for like 2 up to 7 hours, they really couldn't find a difference. And so I think it brings up a very good point that perhaps this is one of those interventions that may not have as much of an impact as we think, but it could reduce some of the absorption early in the exposure. And ultimately, this is one of the guidelines that is similar to basic oral care, where it's a cost-effective intervention with relatively minimal side effects for the patients, and so worth consideration as a prevention strategy. But yeah, that was a great question.
Well, another good question from Mariana, and this one pertains to the microbiome. She's asking, emerging evidence suggests that oral microbiome may influence the development and severity of chemotherapy-induced mucositis. Do you believe microbiome modulating strategies such as probiotics or targeted antimicrobial rinses could have a role in preventing or mitigating mucositis in patients receiving novel agents like antibody drug conjugates?
Yeah, so this is, I don't have any data to say that well, I'll take a step back. Yes, there's a lot more attention being paid to the oral microbiome, and I'll say most of there is understanding that likely contributes. It's just there's still a lot that we need to understand, and the studies have not exactly elucidated where our interventions need to focus. And much of the data in this realm actually is more focused on GI mucositis as opposed to the stomatitis. And so I think there's a lot more we need to learn. There's not strong recommendations for probiotics, but part of that, one of the limitations of this data in general, is sometimes these are such narrowly targeted studies that it ends up that there's insufficient evidence for guideline recommendations. But yes, I think that's Mariana is interested in research topics. Maybe that's something we could look into more.
Yeah, as is often the case in the podcast, many additional potential research questions come up. So this next question is from Luisa Prope in University Hospital Münster in Germany. She's asking about the design of the antibody drug conjugates. She's asking which component of the antibody drug conjugate, the antibody target expression, the linker stability, or the payload chemistry should be prioritized when creating new antibody drug conjugates with a lower risk of mucositis.
Okay. I mean, I don't know if she'll like the answer to this one, but I think they're all important. Like we were talking about earlier, even among drugs with the same target, you can have really varied adverse event profiles. And so they're probably all important. So choosing payloads that have less toxicity, a linker that's more stable, and obviously the target we think, of course, is important, but you know, I wish I had an exact answer for that one. I think they're all important, and we just have to keep paying attention or trying to advance. You know, right now, for example, all of the TROP2 ADCs, they all have the same target, they all have the same payload. So perhaps looking at, I think in the field in general, like advancing the research to find new payloads. Anyway, that's a long-winded answer to your question. Maybe we can
In other words,
edit
all
part
of
of that,
it.
the non-answer.
So, Michelle, this next question is from Natalia Tejeda in Barcelona, Spain, and she wants to know about predictive biomarkers. She says, given the variability in mucositis severity among patients receiving TROP2 targeting antibody drug conjugates, are there any predictive biomarkers? For example, again, the microbiome or transcriptomic that could help identify those patients at higher risk. How might this be integrated into patient selection for more intensive prophylactic strategies?
Mhm. So
all easy questions from our fellow.
again, maybe Natalia can also have this as a area of research. So this is actually an area that the MASC and ISO have identified as a priority because, you know, we have all these targeted agents and we're pushing toward personalized medicine, but we're not quite doing the same in terms of managing toxicity. And there have been a lot of studies that have identified differences in, you know, the metabolic pathways, the signaling pathways, the injury and repair mechanisms, but each one is so, again, so narrowly focused that it's sort of hard to interpret that and then turn it into some, you know, design interventions that would be targeted toward an individual. And so one thing, what we were sort of left with in terms of the MASC and ISO recommendations is that certain things clearly impact the risk, not that they're individual factors, but, you know, dose intensity, type of therapy, female sex, and smoking status. So those aren't really that specific. And I think the short answer is that more research needs to be done. I will say what the MASC guidelines recommend is that there's a more an effort to approach this from instead of trying to design each study to answer one hypothesis, to approach it in a more multidimensional way so that we can start to personalize these supportive care interventions.
Okay. Another question from Rim Abu Chakra from Lebanon. She's asking about dose management, and she says, what's your call on dose reductions versus treatment discontinuation when mucositis recur after managing it? Also, if you have to tweak the dose because of mucositis, do you lean towards trying a different antibody drug conjugate with a new payload, or do you usually stick with the original medication?
So first, I would optimize the management of the AE, and I think in these scenarios, the patient education is super important. These prevention strategies can be really time consuming for patients to do all of the mouth washes and keep up with all of the strategies we recommend. So I think assessing what they are doing, what's working, what's not working, making sure that we have optimized the prevention and management strategies. In the paper, we do highlight for the TROP2 ADCs that exist or currently being studied what their the sponsor recommendations are for dose reductions. Generally speaking, I would say I would not automatically switch to a new agent. I think we have to be thoughtful overall about lines of therapy with these patients, and none of the agents are without side effects. And so you could just be trading stomatitis for, diarrhea, and that could be bothersome. So I would generally approach this stepwise, try to manage the side effects as best as you can, escalate based on grade, and then dose reduce if you need to.
Yeah. Frederica Stroish is asking, is there any data on how often mucositis resolves on its own, and in what time frame? How common are grade 1 or 2 toxicities compared to grade 3s?
So great question. So most of the data that I found is on datopotamab deruxtecan. And so those side effects tended to present, 1 to 2 weeks after therapy and then resolve within a month. But I will say, especially in some of the studies where they were using this first in breast cancer, they amended the protocols to include prevention and mitigation strategies. And so truthfully, without any intervention, I'm not certain. I think we actually should be really aggressive about helping patients manage these side effects. In terms of the grade of stomatitis that we see, most are grade 1 and 2, and across studies, the grade 3 was consistently less than about 10%. And so did not, perhaps because of all the mitigation strategies that were introduced, did not lead to high rates of discontinuation.
Notice how I got myself asking that question without actually having to pronounce datopotamab. So, I'm so glad you did. So now I'm going to actually go to a question from Sofia Bigardi from University Hospital in Italy. And she's asking, this paper discusses interventions like photobiomodulation, benzidamine rinses, glutamine, honey. Which of these appear most promising, and what barriers exist to their adoption in gynecologic oncology? Are there any ongoing trials specifically addressing mucositis prevention in patients receiving antibody drug conjugates?
So, I think all of these have varying levels of evidence and are recommended or suggested in head and neck cancer treatment or stem cell treatments. And so of them, I think the photobiomodulation, which is basically like low-level laser or light therapy that can be used either as prevention or as treatment, might have the most promise in the sense of there are consistently positive results across the studies and well-designed trials that have shown that it can be used for both prevention and treatment. I've personally never used these, but from what I've seen, it seems like once patients understand how to use the technology, it's pretty straightforward and kind of low risk. Similarly, honey is very low risk. I was actually in writing this paper, I was like, oh my gosh, who would have thought honey? Like it's so basic. So I think the photobiomodulation might have the most promise. Generally speaking, we don't have as many agents that have stomatitis as one of the main side effects, certainly not compared to head and neck radiation. And so I think just introducing some of these other therapies and getting our staff and practices comfortable with using these could be one of the barriers. And then in terms of the clinical trials, I'm not aware of any specifically addressing this or looking at these, certainly not in our disease sites.
Yeah, so perfect follow-up with this question for Natalia Tejeda in Barcelona. And she's asking, if you were to design a clinical trial to test one of these strategies specifically in patients receiving TROP2 targeting antibody drug conjugates, which intervention would you prioritize and why? And I think based on your previous answer, I think honey is at the top of the list for that one.
Yes, cost effective and accessible for sure. Yeah, and then second to that would be the photobiomodulation, and then this might address one of the other questions someone asked, but in terms of assessing what's actually working for patients. So I think right now there are a lot of things that we say you should do, the mouthwashes, and like I said, that can be time consuming for patients. And so maybe parallel to our efficacy assessments, really understanding what's working for patients. And if there is a treatment that they can do twice a week, like some of the photobiomodulation protocols, in terms of quality of life, that could have a real impact as opposed to doing 4 times a day mouthwashes every day.
Mm-hmm. So Michelle, just 2 more questions that I have for you. And this one comes from Luisa Propane. She's asking, in your practice, which one of the treatment strategies for mucositis has the greatest impact on allowing your patients to continue therapy without dose reductions or delays?
Mm-hmm. So 2 things. One is really spending the time with patient education up front. And so when I'm even discussing some of these drugs with patients, being very clear what the preventative strategy is, so that we're all on the same page and they understand that that is part of the treatment and are really committed to the prevention strategies. And then I would say the steroid mouthwashes.
So now, Michelle, as a new tradition in our podcast, the last question actually comes from AI, as AI interpreted your paper. So this is a question from our AI agents. Your review emphasizes that mucositis is often self-limiting, yet it can lead to dose delays, reductions, or discontinuations that compromise efficacy. Do you believe current management strategies are sufficient to truly preserve treatment continuity, or should mucositis prevention be considered as critical as tumor response in future trials with antibody drug conjugates?
I see. Okay. I feel like AI should answer this one. But no, I think both are true. Like I was saying, it is important to know how this affects patients and understand what actually works so we don't burden them with all the interventions. But what we've seen is that being proactive, using prevention strategies, monitoring patients closely and really supporting them if they do develop stomatitis will keep them on the therapy. And, some of these therapies from what we know across our tumor types, and we highlight this in the paper too, is can have higher efficacy than some of the other existing drugs. So if we can manage the side effects like we would any therapy, that can have a real impact on patient outcomes.
Well, Michelle, thank you so much for your time. I really enjoyed speaking with you. I've learned so much. I really feel that, certainly this podcast, after recording it with you, should be a resource for our patients that ask about oral mucositis. So thank you so much for putting the time, the effort, for teaching us about how to manage this condition, and for sending this manuscript to our journal. Thank you once again for accepting our invitation.
Great. Thank you so much for having me, and for all the fellows for sending their questions in.